So we're going to be talking about a 36-year-old man with an unintentional opioid.
Vicky. Okay, so first I'm going to talk about the case history. And before, I just wanted to say that opioids are a large class of drugs that ranges from legal to illegal to synthetic. And some people might not even know the effects that they're taking and the drugs they're taking into them. So, our case is of a 36-year-old man who is a high school graduate. He worked as an electrician before he became unemployed. He was single. He only smoked about half a pack of cigarettes for about 4 years. He smoked marijuana when he was younger. He doesn't drink no other illicit drugs besides heroin. No medical conditions, no medications, no allergies, no family history of depression, bipolar disorder, schizophrenia, dementia, or suicide. So as you can see, he's a very normal, everyday man. And then everything happened about 4 years ago when he got a unspecified hand surgery. And during his stay at the hospital, he was given morphine, and hydromorphine is a very, um, it's very dangerous. It's highly addictive, but it is used as a painkiller for severe to moderate pain, and doctors often use it. And then when he was discharged, he was given prescription opioids, which he switched out of before completing. He switched into intravenous heroin because it was more accessible and more affordable. For the next 3 years after, he injected 1 to 2 grams of heroin daily. 1 year prior to the incident, he became unemployed and he attempted to stop using heroin for the first time. To do this, to cope with his withdrawal symptoms, he tried methadone, which is an opioid, but it is very, you could use it as to battle opioid dependence. And a lot of people have this misconception that if you use an opioid to fight an opioid, it's like changing an addiction with another addiction. Yeah, with another addiction. But it's actually been proven with many cases to be very helpful for the patient as long as you follow a proper regimen. But he did not get the help that he needed, so he wasn't able to come through with it. He only lasted 10 days with this treatment. So 6 months ago, he stopped again for the second time heroin use and was admitted into an inpatient detoxification program. This time he lasted a little bit longer, about 2 weeks, but he once again started heroin use. And then 2 months prior, he was released from jail. He was admitted into a residential rehabilitation with work therapy, NA meetings, and intermittent urine toxicology screenings. He did pretty well until only 3 days prior to the incident when he resumed opioid use again. And then, as you can see, I put a little cycle of the addiction that he has fallen into since his hand surgery. With his first exposure, he led on to more opioid use, and then he tried to follow up with detoxifications and then treatment, which was all unsuccessful. And as you can see later on, he falls into the last step, the overdose. So the day of the incident, 10 a.m. he injected zero point 0.5 grams of heroin. At 1:30 he injected another zero point 0.5 of heroin. But at 2:44 he was found lying unresponsive at the point. Why would that be? He's been using heroin for the last 4 years, 1 to 2 grams daily, but today he used it only 1 gram, and he's already OD'd. So when he was found, his health stats were not that bad. His temperature was 35.6 degrees Celsius. The range is around 36.5 to 37.5, so it wasn't even low enough to be considered hypothermia. His pulse was 88 beats per minute, which was in the range. His blood pressure was 122 over 76. His systolic pressure was a little bit over, but it wasn't even. So from 120 to 139 is considered pre-hypertension, so it wasn't even in the next category. hypertension. The most concerning part was the respiratory rate, with only 4 breaths per minute, while the average is from 12 to 20, meaning that he wasn't getting enough oxygen to sustain his body. And you can see that from the oxygen saturation of only 80% when the average is from 95 to 100%. His blood glucose level was 164 milligrams per deciliter, and the average is from 70 to 110, but it may have been high due to the stress level that he was feeling, stopping heroin use, and then his OD. So it was reasonable.
Now, moving on to the second part, I will be talking about a couple examinations done on him and then ultimately his final diagnosis. So he got several treatments for his overdose. So first, what happened was he was supposed to meet his friend in this part. So when his friend found him unconscious, he gave him an initial dose of intranasal naloxone. Intranasal meaning through the nose, and then naloxone is a chemical which blocks opioid receptors and starts to undo the overdose. His friend also called 911, and when the first responders came, they gave him a second dose of this medication and administered oxygen. Then they transported him to the emergency department. So the initial examination, he got a score of 3 on the Glasgow Coma Scale, which basically just means he was deeply unconscious. The Glasgow Coma Scale is based on 3 criteria: eye-opening, verbal response, motor response, and has a score from 3. So he scored the lowest. He also had a cyanotic appearance, which just means he had bluish purplish skin, which suggests that he was not getting enough oxygen. And then, of course, he also had shallow breathing, only 4 breaths per minute, and pinpoint pupils, which is abnormal. Upon arrival to the emergency room, they did another examination, and by this time he was alert and oriented, where he had been unconscious, and he had normal breathing at 16 breaths per minute and normal pupils. However, he was still found to be hypoxemic, which just means he had like low levels of oxygen in his blood, and he had crackles, which is a type of sound in his lung, which was abnormal. So the next step was to do radiology. They took this x-ray directly upon arrival, and then they took a couple more 20 hours after arrival. As you can see in these x-rays, there are these patchy obscurities in his lungs down the brachial tubes, and these are indicative of fluid in the lung. So the condition of fluid in the lungs is called pulmonary edema, and there are 2 types of pulmonary edema. There is cardiogenic, which means that the cause is usually heart-related, so there are elevated hydrostatic pressure in the pulmonary capillaries following elevated pulmonary venous pressure, and this usually indicates left-sided congestive heart failure or another heart problem. On the other hand, non-cardiogenic pulmonary edema means that there are changes in capillary permeability due to direct or indirect pathogenic cause. So common examples of this would be drowning, aspiration, allergic reaction, etc. And so the doctors reviewing his case decided that he had non-cardiogenic edema and that it was opioid induced. So he was given a final diagnosis of opioid induced non-cardiogenic pulmonary edema for the fluid in his lungs. He was also given the diagnosis of opioid use disorder for his addiction to heroin and opioid overdose. However, what caused his overdose um, was unknown because, as Vicky said, it doesn't make any sense that someone who used heroin for 4 straight years would suddenly overdose after taking only a relatively small amount. So, 16 hours after his arrival, they did an immunoassay, which tests for drugs of abuse, so heroin and other illegal drugs, and it uses a urine sample. And this test was negative. They did not find a large amount of heroin in his blood at all. So this led the doctors to believe that maybe he didn't overdose on heroin, even though that's what he thought he was taking. They later tested for fentanyl, which is not detectable in standard drug tests, and this test was positive. Now, fentanyl is structurally different from both morphine and heroin, as you can see on the slide. It is 50 to 100 times more potent than morphine and 30 to 50 times more potent than heroin. So it is extremely potent. And basically, it's it's synthesized and it's used to lace drugs like heroin or Xanax to make them seem more potent. But this is actually dangerous because you can take more than you expect.
Okay, so now I'm going to be talking a little bit about fentanyl and the opioid crisis. Um, so generally, 3 out of 4 new heroin users have previously abused prescription opioids, and 9 out of 10 people who use heroin use at least one other drug. Um, and what was interesting and relates to our case is that the heroin death rate for males ages 25 to 44 in 2015 was 13.2 per 100,000, which is above a 20% increase from 2014 to 2015. And so this graphic just shows the light blue dots are 2014 and the dark navy dots represent 2015. And what I thought was interesting is the change. Heroin overdose death rates is the greatest. I'll be talking a little bit about this just shows that the age-adjusted death rates per 100,000 are increasing in all of the U.S. regions. And what the CDC means by age-adjusted rates is that these rates give fair comparisons and a better representation among states that have different age distributions. And the CDC uses the US population in 2000 for standard epidemiological purposes. And this just equalizes the playing field, and so we can regions. So going back to fentanyl, a majority of deaths from fentanyl correspond to illicitly made fentanyl, which is generally sourced from China and Mexico. And illicitly made fentanyl is normally seen as powders, patches you can put under your tongue, and in pill form. And then the fentanyl that is used, like the hospital version, includes injections, patches, and lozenges. So there are legal and illegal forms of it. For instance, in California, fentanyl was passed off as a drug called narco, and it was responsible for 10 deaths in 10 days. So just very dangerous and very potent. And the charts or the maps of the U.S. Show the law enforcement fentanyl encounters in 2013 on the left and 2015 on the right. And as you can see, there's a very large or significant increase in the encounters, and they mostly correspond to um, illicit fentanyl encounters that is showing increase in encounters. And then these maps show 2014, 2015, 2016, the increase in drug overdose deaths by state. So as across the U.S., very significant increase. Um, and so these maps show 2015 or 2014 to 2015 increase on left, and the 2015 to 2016 increase of drug overdose deaths on the bottom right. And going more detailed into specifically Maine, there has been a 26.2% increase in the drug overdose death 2014 to 2015. And between 2015 and 2016, there was a 35.4 increase in the rate. And there have been 259 drug overdose deaths in 2015 in Maine and 353 deaths in 2016 in Maine. So in Maine, when I was Googling, this popped up that over 185 people died from drug overdoses just in the first half of 2017, which is pretty shocking, and that fentanyl caused at least 61% of these deaths. So going into kind of the Waterville community, it's this fentanyl, heroin, and these other hard drugs and drug overdoses are shockingly, for me at least, kind of very prominent in Waterville when I was like Googling everything. And so the Waterville police chief, Joseph Massey, has said that many times these illegal drugs are cross-contaminated with other drugs, such as heroin being laced with fentanyl, making it a very dangerous and sometimes lethal cocktail for the user, which we have seen with the case of the patient. And so recently, this was 1 year ago, last January, 2 people were arrested for $45,000 worth of drugs found on water. So it's a pretty big problem here, although there is being a lot done to stop it. So before I go into that, a couple of the general takeaways that some of the doctors presented in their case with the man is that, and as Vicky mentioned about the addictive cycle of these drugs and drug overdoses, is that includes addiction, detoxification, treatment, and overdose. And opioid addictions can develop after exposure to prescription opioids, which is very common, like we've previously mentioned. And so there needs to be less access to opioids and emphasis on education in terms of mainly better training for physicians. Right now, many physicians are not prepared to discuss long-term treatment options with patients or don't feel comfortable. So simple detoxification is not just the solution, because then it's possible that the patients go back and overdose again, and they have to see the physicians again. Again, the physicians may not be comfortable prescribing the adequate treatment. And then there's also the stigma that needs to be combated in terms of removing the stigma that is the misconception that medications that can treat opioid agonist therapy don't replace one addiction with another, and they're actually effective. So there have been state successes in terms of prescription drug monitoring programs that have worked in Ohio, Kentucky, Florida, New York, Tennessee, among other states. So their progress is being so in Waterville, one of the interventions is that a year ago, the Waterville Police Department initiated Operation Hope, which is the heroin opiate prevention effort, which is pretty successful and provides a focus on enforcement, education, and treatment. So one of the major problems in Waterville is that drug suppliers from surrounding regions come in and attempt to sell their drugs to local dealers, so including heroin laced with fentanyl. So that's one of the problems as to why it's such a big problem in this region, people coming in. But then this program, what people can do is that if they have any drug paraphernalia, they can go to the police station and turn it in and then get screened for any past crimes and then apply for this program. And they'll be placed in a residential treatment center. And then there are people called angels who are volunteer people who come in and attempt to place these people in the treatment centers and help them out, get situated, and try to fight against their drug addiction. And well, last thing is that the a positive change has been seen because the Waterville Police Department, or this program, has partnered with programs such as the nonprofit Healthy Northern Kennebec County program, and this kind of segues into bringing police officers into schools in hopes of educating young students about the dangers of drugs and drug overdoses. And I think this step is important in preventing increasing rates of drug overdoses in future generations, but also what we've talked about before is trying to prevent or trying to educate the physicians better on the front line is also really important, and as well as two sides. Big problem, but going in the box.
Any questions?
About so you talked about how educating doctors on how to deal with opioids, anything preemptive, actually not that's in severely severely over medicated prescribed. There's
When
a
there's
lot of
other options.
Yeah, a lot of times opioids are incorrectly prescribed, which is what happened with our patient. He incorrectly prescribed the medication for like his hand surgery, and that led to addicted. And our case like actually talked about like one of like the major things that they need to be doing is teaching doctors how to prescribe correctly and how to like treatment plans with their patient so that they don't become addicted to them. And a lot of times, like, doctors don't really know anything about like addictive medication, and so yeah, um, kind of like education needs to start with.
And doctors, like in our case, he didn't have to use this medication. He could have used another. There are many cases where it's like they shouldn't be using this one unless because it's highly addictive. And if he drank any alcohol, he would be like in danger, in severe danger. And then so like doctors should not be such highly addicted unless it's like the last option, no other options for this patient for certain reasons or like other conditions. But this man, he was healthy. He could have taken some other painkiller, and it was only a hand surgery. So it was like, and that led to this addiction. It was that first exposure.
Papers and discussion, they talk about this. They talk about training it, overcome stigma. Well, not knowing, not there being mental. So yeah, you better describing, but also system break them again. What I think is interesting talking for prescribing practice is that physician, is that original prescribing liable for having issues with class 1 narcotic
That wasn't really necessary.
that was not necessary
in
at
this
all.
case.
It led to this mess. So I had, yeah.
No, just stretching.
Yeah. Yeah. Is what's one of the dangers of naloxone? Why was it important that the EMS established what the friend? Like what was what that little where you talk about Buddy shows up, fortunately with naloxone in his pocket, and then administers it intranasally. The response calls EMS. They show up.
Give it a
And
second dose.
administer some more. What was the potential danger?
Well, I'm sure they could have accidentally given him too much, and then it's two drugs that are.
What's the danger?
I'm not entirely sure on this, but in one of the articles that I read with fentanyl and naloxone, there's something like it may not work properly. There's some.
You can if you over administer some type of withdrawal, it can be quite dangerous. Not as dangerous. It's wise to have it on hand if you are an addict. So establish how much they walking into a situation. Hal Park, if he had naloxone, he was probably you're walking into an We'll let it go there. Thank you very much.